Buenos días. Agradecemos su presencia en este webinar de Universidad Levet. Está con nosotros el doctor Tommaso Castrucci y Vivian Barberi. El día de hoy, en colaboración con Universidad Levet, nos presentan el tema Endovascular Approach to Carotid Artery Stenosis with Flow Inversion Cerebral Protection. Las indicaciones para los asistentes son las siguientes. En la parte superior de su pantalla encontrarán unos iconos. Uno de ellos es un signo de interrogación. Si durante la ponencia tuvieran alguna duda, pueden agregarlas dando clic en el icono mencionado. Si el acceso fue a través de un teléfono celular, en la parte izquierda encontrarán el icono con el signo de interrogación para agregar sus preguntas. Al finalizar la ponencia, los doctores nos darán respuesta a cada una de ellas. We appreciate your assistance in this webinar of Levet Medical. The Dr. Tommaso Castrucci and Vivian Barberi are with us today in collaboration with Levet University. They present you the topic Endovascular Approach to Carotid Artery Stenosis with Flow Inversion Cerebral Protection. The instructions for the audience are: if you have a question in your screen, you can look at question button. If your access was in a mobile, in the left of the screen, you can see the question button. Here you can write in, and when the topic ends, the doctor answers all the questions. Welcome to this webinar. Now, I give the floor to Vivian Barberi. Sean bienvenidos. Cedo los micrófonos a Vivian Barberi.
Buenos días, buenas tardes, muchas gracias por la participación de todos. Muchas gracias al doctor Tommaso Castrucci por aceptar la invitación de Inspire MD y LevVet en brindarnos con esta linda presentación del día de hoy. Doctor Tommaso Castrucci es un cirujano vascular del Hospital San Eugenio de la ciudad de Roma, Italia, y hoy nos brindará con esta linda presentación. No tomando más el tiempo, le abro el micrófono al doctor Tommaso. Doctor Tommaso hará la presentación en inglés, a pesar de él comprender muy bien el idioma español, pero es más fácil para que lo haga en inglés. Cualquier cosa, contestará las preguntas también en español. Doctor Tommaso, welcome. Muchas gracias. Gracias tanto por tu presentación.
Good morning, buenos días a todos. Gracias por esta invitación y desde este momento voy a hablar inglés, que para mí es más fácil. So I prepared a presentation on endovascular approach to carotid artery stenosis, and I started with the very basics of endovascular surgery. This is because many vascular surgery are not accustomed to vascular access, and vascular material, endovascular access and endovascular material. So let's just get going, and just a second. Okay, here it is, and we're on air. So I'll do this presentation with a particular regard to flow inversion cerebral protection, because it's the way we do carotid artery stenosis in Santo Eugenio Hospital. A few words about the comparison between carotid artery stenting and endarterectomy. Many studies, many papers have been published, and usually it comes out that endarterectomy is more efficient than stenting in carotid artery stenosis. Though a few papers in which the operators were equally qualified to do both procedures demonstrated that on the long term, these two different approaches are equivalent. The Sapphire of 2004 was a non-inferiority study suspended prematurely due to the good results. It enrolled only 307 patients, equally divided between the two techniques. The primary endpoints were stroke, death, myocardial infarction at 30 days, and there was, as I said, a good selection of operators who had to have complications minor than 6%, and there was a routine use of cerebral protection. The results were good. We had a technical success in 95.6% of cases. The primary endpoint was in favor of endarterectomy. The reinterventions, though, were quite a bit lower in stenting. There was obviously no cranial nerve injury with carotid stenting, while we had a 5.3% of them in endarterectomy. and the 3 years follow-up showed no statistical difference in the outcomes of the two groups. The second study I want to name is the CREST of 2010. As you can see, they're quite old studies, because the question actually is not if it's better to stent carotid arteries or to endarterectomize them, but the comparison is now between the two techniques and the best medical therapy that has evolved quite a bit in the last years. This study was sponsored by the United States Institute for Neurological Disorders and Endovascular, so there might be quite a small bias in favor of stenting due to the sponsors. Anyway, it enrolled quite a high number of high to moderate risk surgical patients. The use of cerebral protection was compulsory, and it was an RXA Acunet by Abbott. The primary endpoints were the same as usual, so death, stroke, myocardial infarction at 30 days, ipsilateral stroke at 4 years. The operators had to be experienced. They had to have performed 30 stentings, 20 of which with Aculink and Acunet devices. As you can see in this case, the outcomes were slightly in favor of stenting, especially the disabling stroke weren't that different between the two groups. Myocardial infarction was quite a bit lower in stenting. Ipsilateral stroke was double in stenting as in SIA. Stroke was double in stenting as in endarterectomy. But anyway, those were all low numbers. So what do we need to approach the carotid artery? We need a Seldinger, a hollow needle, an introducer sheath, catheters, guide wires. I'll take a look at all these things just to put us all on the same level of knowledge. So the Seldinger technique, it consists in a percutaneous puncture of the artery. In this case, it's a femoral artery. As you see, the needle goes into the artery, blood comes out. You put a guide wire, that's an 035 guide wire, into the artery, remove the needle, and you've got a safe access to the femoral artery. Next phase is the positioning of an introducer sheath. These can differ from each other in the internal diameter. Remember, when the Frenchage of an introducer sheath indicates the internal diameter, the length, the form, and the presence or not of a hydrophilic coating. So the introducers are prepared, as you probably all know, by washing inside with heparin saline solution, introduction of the mandrine, and these are all straightforward procedures common to any endovascular approach. So the introducer is then set onto the guide wire that was previously positioned into the artery, and the mandrine is removed. In the animation, you can see that the guide wire is removed with the mandrine. This should be avoided because sometimes it's quite tricky to get past the iliac artery stenosis or kinkings, and it's better if you position the guide wire into the aorta. You should better leave it there. Going to the guide wires, most of you are familiar with endovascular treatment of aneurysms, so you know what we're talking about. The diameter is 035, 018, 014. These are the most commonly used. The lengths and the stiffness are very important, and the presence or not of a hydrophilic or Teflon coating. The tip form can be straight, angled, or J. Actually, J is not common in use in endovascular surgery. Finally, the catheters. Usually, I don't use a catheter to gain the access to an artery, except for quite difficult arteries, quite difficult aortic arches. So you can use a SIM or a crossover or a cobra-shaped catheter to gain the access to the common carotid arteries. Secondary, we position an guide cath. A guide cath is a catheter with a big lumen that's hasn't got a valve, and that's the main difference that we've got with the introducers. because it's secondary placed, and you can wash the catheter through the lumen. So they differ one from another for the diameter, and this time it's external. So a 6 French introducer works with a 6 French guide cath. This is the preparation, and well, balloons, they differ one from another for the diameter, length, the pressure, the shaft length, coating, special balloons, cutting balloons, compliant tri-lobe balloons. Something I want to point out is the difference between the catheters. So you have over the wire or monorail. When you're performing an endovascular access to the carotid artery, you will be using monorail catheters and stents. That means that only a part of the stent travels actually on the guide wire. The rest of it isn't on the guide wire. That allows rapid exchange of the stents, because in this procedure, velocity is a key feature of the procedure. My teacher told me that you have to be as quick as a thief when you position a stent in the carotid artery. That's to reduce the possibility of cerebral embolization. So, stents, general feature. The main thing is the difference between balloon expandable and self-expandable stents, open cells versus closed cells, and in the last years, double layer stents, and we'll have a closer look at these as well. So what's the main difference? A self-expanding stent is made of a foam memory material, and that assumes their primitive form at 37 degrees Celsius. They have a good radial force, and they will continue pushing the stenosis throughout time after the positioning, whereas balloon expandable stents are pre-mounted on a balloon and assume the maximum diameter thanks to the inflation of the balloon. These allow a very, very precise positioning, but don't have a big radial force. So the result you achieve during the procedure will be the definitive result. Go on. So, what are the risks of these procedures? Apart from the general risks you have with endovascular procedures, mainly due to the access site, there are embolization risks, and the most important moments in which this risk is maximum are the navigation through the arch, the brachiocephalic trunk, and the common carotid artery. The presence of unstable plaques in the arch can easily generate microemboli who will give microinfarctions in the brain. Even if they're not all ipsilateral to the procedure, you can find them in a diffusion MR scan later on. The filter positioning is a risky phase of the procedure. The pre-dilatation, the stent placement, the plaque protrusion through the stent cells, especially if it's an open cell stent, they're not anymore used in carotid artery stenting. The post-dilatation, the incomplete filter covering. So any debris, if the filter isn't positioned well, it doesn't adhere to the vessel walls, some debris can go through that and give you embolization to the brain, and the filter overfilling in case of gross quantities of emboli. So the cerebral protections are got various types of cerebral protection. The first one on your left is the filtering. That means you position a filter beyond the lesion before you start dilating and stent positioning. The second is a derivation. It's a small balloon mounted on the guide wire. It stops the flow in the internal carotid artery, and any debris should go to the external carotid. Then you've got a full stop. That's the MOMA. It's a balloon in the common carotid artery and the balloon in the external carotid artery. That's a surgical procedure. A surgeon invented this system, and it's very, very safe, but quite tricky to use. At the end of the procedure, you aspirate 20 to 60 cc's of blood until no debris are found in the blood aspired, and then it is given as the bifurcation is clean. A full reverse is the same thing, only the catheter is connected to a vein with a filter interposition, so you've got a retrograde flow from the internal carotid artery all the time of the procedure. And the last one is the one I want to talk specifically about, is a simplified reverse with a balloon positioned in the common carotid artery, no balloon in the external carotid artery, and this gives a spontaneous backflow from the internal to the external carotid, and by opening of an AV fistula with the vein, it will give an increase in the in the retrograde flow velocity. So this is a slide which reassumes the different types of cerebral protection. Into the first one, none, is only used by interventional neuroradiologists when they perform procedures on the cerebral arteries. This is absolutely no protection, and I wouldn't advise anyone to use this system. So we've got the filters, the distal filters, the TCAR that consists in a preparation of the common carotid artery with a very short introducer sheath, and the looping of this will stop the flow in the common carotid artery, and aspiration of the system will allow eventual debris to flow to the vein compartment. So, a few words on the different stents. I will only talk about the stents I actually use in my practice. The workhorse for everyone is the carotid wall stent from Boston Scientific. It's an alloy, it's a metal alloy stent, closed cell, no mash, and it's got quite a big porosity. The two stents with a double layer that actually are available on the market are Road Saver by Roma and Seaguard by Inspire MD. Have a closer look to these two. The Gore carotid stent actually hasn't reached the market yet, and I doubt it will, because it's a few years that there's a lot of talk about this stent, but no one has actually ever seen it or used it. So let's compare the Road Save, previously known as Casper, to the Seaguard by Inspire MD. They've got a different stent frame. The frame of the Road Saver is a closed cell nitinol, as the whilst the Seaguard has got an open cell nitinol. The difference is the double mesh. The mesh is put inside in the Road Saver and outside of the Seaguard. The fabric is a nitinol for the Road Saver, for the mesh I mean, and PET for the Seaguard. As you can see, the porosity is similar, but it's lower in the Seaguard. For looking at the porosity, the big yellow disc represents the area of porosity of a carotid wall stent. That's 1,000 microns, whilst the smaller porosity is the Seaguard with only 165 microns. That makes you sure you won't have plaque prolapse through the cells during your procedure or after the procedure. There won't be a cell migration to give an hypertrophy of the under stenosis. So what are the advantages and disadvantages of these different stents? I think the Seaguard's pros are the minimal porosity, the flexibility once deployed, it's very trackable at x-rays, it doesn't shorten when you're releasing it, it has a very high diameter adaptability, and the meshing is external. I think that's better because the pushing stent is inside. The struts will push against the outside mesh that contains the plaque actually. What are the back sets of this? It's got quite a rigid deployment system. It needs an 8 French guiding catheter. That's quite big for a carotid artery. It's got a low radial force, and it's not indicated in highly calcified lesions. It requires predilation. That means that if you're using a filter system and your plaque is very, very soft, you can easily have an overfilling of the filter position after the plaque. This animation shows you how flexible the stent is and how well it adapts to the vessel walls. So it's released and it really goes softly onto the walls and adapts very well to the different diameters of the vessel. The carotid wall stent is probably most used stent in the world. It's by Boston Scientific. It's pros, it's got a very high radial force, so the result will get better throughout time. It's very flexible. Its deployment system is flexible. It's highly trackable. It doesn't shorten when you release. It's got a high diameter adaptability, and it only needs a 7 French guiding catheter. The backsets of this at the state of the art are its high porosity, and it's quite rigid once deployed, so it will straighten up kinkings, and this could give acute angles of the internal carotid artery after you've deployed it. This is an animation showing how the carotid wall stent works. As you can see, it can be partially released, reintroduced in the introducer system, and re-released. This stent, as you can see, conforms to the vessel wall very well, and it needs a post-dilatation. It's usually positioned with post-dilatation technique. Here it is. You don't need to achieve an incredible lumen. First of all, because a residual stenosis of 20% is acceptable. And in the second place, the stent will continue working in the days subsequent the procedure. And the last one I want to talk about is the Road Saver by Terumo. The pros are a very flexible deployment system. It's got a very good adaptability to kinking, and it only needs a 5 French guiding catheter in the small diameters. The back sets are that the mesh is internal, so this doesn't stop cell migration from the plaque into the stent. It's got a high shortening ratio, so it's very difficult to choose the right stent for your carotid artery, and it's not very trackable at X-rays. So how do we perform which are our patients? So we know there are 2 groups of patients in which arthrectomy or stenting are highly recommended. So for stenting, it's post-radiation stenosis, restenosis, stenosis plus occlusion, and in very high-risk patients, whilst arthrectomy is highly recommended in highly plaqued arches, as I said before, iliac and femoral occlusions, and aortic arch anomalies. All the other patients, I think you have to confront the surgeon's skills with the patient's preference. If the surgeon is a skilled stent deployer, he can easily put stents in all the rest of the patients in between the 2 groups. So when I said anatomic difficulties, I mean, type 3 arches can be quite tricky, especially for the right carotid artery. You've got acute angles in that sort of patients, and you don't have a stable access to the carotid artery, as you see in the CT scan, whilst the kinking after the stenosis, as you see in the small CT scan, is usually not a problem because, as everyone knows, the stenosis regard the first part of the internal carotid artery. So you can precisely position the stent before the kinking, or use a highly adaptable stent like the Terumo Road Saver or the Seaguard, and that won't be a real issue. So the basic kit, as I said before, that we use in our institution is mainly, the highlight is on cerebral protection. We use Flowgate 2 to obtain a flow inversion, or Epifilter to obtain a protection filtering after the stenosis. The three stents I talked about are C-guard, carotid wall stent, and road saver. So what's the technique for distal protection? We use a 7 or 8 French short introducer, 035, 180 centimeters angled tip hydrophilic guide wire, 7 or 8 French that comes on the stent you want to use, Mach 2 guiding catheter, 40 degrees for the left carotid artery, MP for the right carotid artery. We use a constant washout of the catheter with the heparin, saline, and pressure pump to wash it. Filter wire, EZ, also known as epifilter, semi-compliant monorail balloon 20 by 5 millimeters, a pressure inflation system, that's the in-core, and a MyShell epsilon connector. So the technique is access to the common carotid artery with a guide wire and the guide cath and the 035 guide wire. First of all, you perform a diagnostic angiography that contains the cerebral circulation as well. You don't only need it to plan your stenting, but to control which vessels in the brain are patent before the procedure. So then the next step is the epifilter positioning, as you can see in the angiograms contained here. Predilatation is mandatory with C-guard and is very, very useful when you've got a pre-occlusive stenosis. Then the stent is positioned. Post-dilatation, especially if you haven't performed the pre-dilatation before. Then the filter removal, and finally a control angiography comprehensive of the cerebral circulation to control if you've got anything new happening in the brain. So this is an example in which I couldn't use the flow inversion. It's a very, very tight stenosis of the common carotid artery near its origin. So there wasn't space to position balloon catheter there. And we proceeded by positioning a distal filter, dilatation, and what you see there is a C-guard stent that, as you can see, is very visible at angiogram. So what I really wanted, let's get to the focus of this presentation, that is the flow inversion we use at Santa Eugenia Hospital. So the patients we enroll for this type are, as usual, over 70% NASH always, or 50% symptomatic stenosis, high-risk plaques. There mustn't be a contralateral significant stenosis or occlusion, and no Willis circles anomalies, because these would increase the risk of a clamping cerebral ischemia. A preoperative supraortic CT scan is mandatory. It's better not to find surprises during your procedure. It's better to know everything in advance so you can choose your material properly. You can choose your stent sizes, your stent lengths, and perform and plan your strategy before the procedure. We also always perform a preoperative cerebral magnetic resonance just to check if there's important lesions in the brain. So the material, we use an 8 French short introducer, 035 180 centimeter angled tip hydrophilic guide wire, 8 French Flowgate 2 balloon guiding catheter, 014 angled guide wire. We made a do-it-yourself AV connection tube that I'll describe better in the next slides, the semi-compliant balloon on monorail, pressure inflation system, and an epsilon connector. As you can see, there's different types. I prefer the push and pull one that's easy to use and allows very rapid exchange of the material. So how do you prepare the Flowgate 2 balloon guiding catheter? First of all, you connect the epsilon connector to the through lumen of the guide wire of the guide cath, wash it with heparin saline. Then you introduce the dilator that, as you have seen, is very, very flexible and has got an angled tip. You wash it with a heparinase saline solution. The next step is the preparation of the balloon. First, all of the air contained in the small tube that connects the valve to the balloon must be removed with inflation solution. The inflation solution is very, very liquid. I use a 20% contrast media, 80% saline, because of the small diameter of the connection tube. If you use the more concentrated solution, you'll have trouble deflating the balloon at the end of the procedure. So the balloon is deflated, the last air bubble comes away, and the guiding catheter is ready for use. So this is a scheme which reassumes how the connection is made with the peripheral vein. There's a 16G cannula inserted in a peripheral vein. I usually use the forearm for this. If there are no good veins in the forearm, you can go for the arm, but that means that your connection will be longer and the resistance to flow will increase. So there's an extension tube, double female connector, that's not very easy to find on the market. Three-way stop clock that you'll use to wash, to inspire, and to perform your angiographies. And that in the lower right side of the slide is a photograph of the construction, let's say. So the procedure. As in all procedures, the first step is the positioning of an 8 French introducer sheath, access to the common carotid artery or a flow gate 2 and an O35 hydrophilic guide wire. Pre-access with a particular catheter isn't nearly ever necessary. This is it's got a very flexible dilator, what will help the catheter to travel easily to the common carotid artery. The duplex monitoring of the internal carotid artery flow. This slide shows something you shouldn't see, that is the radiologist colleague that was monitoring the flow got caught in this picture, but it's quite nice to see what we actually do. So a roadmap acquisition, flow gate 2 tip balloon inflation, opening on the AV connection, pre-dilatation with a 5mm semi-compliant balloon, stent positioning, selective post-dilatation, tip balloon deflation, and closure of the AV connection. We deflate the balloon before closing the connection so that the flow will increase, the retrograde flow in the catheter will increase and wash out any debris. And at the end of the procedure, naturally, we will perform a control angiogram. So what's the duplexing like during this procedure? This is prior to dilation, the pre-flow gate inflation. As you can see, it's a typical pattern of an internal carotid artery. There's not excessive acceleration. This was a 50% stenosis, symptomatic with an ulceration, as you can see on the angiogram. What happens when you inflate the balloon is that you'll get a partial retrograde flow that goes to the external carotid artery. This will increase in a dramatic way when you open the AV connection to the vein. The loss of resistance in the peripheral vein will allow any debris to flow away. So our experience in this our experience with flow inversion, the ones we registered and we're going to publish are actually in peer review, of 45 patients we treated in between February 2018 and February 2020, of which 34 were males, 11 females, 6 symptomatic with stenosis greater than 50%, 39 non-symptomatic with stenosis higher than 70% on a NASHET basis. We In our country, carotid artery stenosis, as you know, is performed mainly in non-symptomatic patients. We perform it in symptomatics as well, but the large numbers come from the non-symptomatic groups. So the exclusion criteria were patients with ischemic stroke within the previous 48 hours, the total exclusion of the target vessels or the contralateral internal carotid artery. That's because you had a high risk of clamping ischemia, previous major stroke, myocardial infarction 72 hours before carotid artery stentings. We perform many stenting procedures with the cardiologists who do coronary angiogram and eventually position coronary stents, and subsequently we position in the same operation, during the same operation, we position carotid stents. So contraindication for magnetic resonance was a exclusion criteria for this study. Contraindication for antiplatelet and/or anticoagulant therapy must be a contraindication for any sort of stenting, because there's a very, very high risk of thrombosis, of stent thrombosis, intraoperative and in the immediate postoperative day. We keep these patients on dual antiplatelet for at least 3 months after the procedure. So another exclusion criteria was the presence of coagulation-like disorders, gastrointestinal bleeding within the last 30 days, and allergy to contrast agent and to aspirin or clopidogrel. And that's the same reason for the antiplatelet. So which were the outcomes? We were very happy with this experimental work. The mean time of flow blockage was only 4.2 minutes. Minimum, it was 1.7 minutes. Very rapidly, we managed to position the stent and restore flow. As I said, speed is an issue in these procedures to keep the clamping ischemia as low as possible. Vascular surgeons know that clamping time is better to keep it down. We only find grossly visible particulate debris in 6 of the 45 procedures. The mean duration of the total procedures was 31 plus or minus 12.3 minutes. That means it's a very, very fast procedure. You get down to 18 minutes minimum. Transient clamping intolerance was observed in 2 patients. In 1 patient, the neurological deficit persisted for 3 hours. The other patient resolved as we deflated the tip balloon. 1 minor stroke occurred 8 hours after the procedure without DVI microembolic lesion visibles. No major strokes or deaths were observed at 3 months follow-up. TWI demonstrated contralateral microembolic scattering in 1 asymptomatic patient, and that was probably due to the navigation through an not perfect aortic arch. No patient had changes in NIHSS scale and neuropsychological assessments before and after that we performed before and after the procedures, and patients were all discharged after a median of 2 days from 1 to 4 days range. So this is all that I can say about flow inversion, carotid artery stenting. Looking forward to seeing you in Rome. Come and visit me at my institution. We can perform something together. And the final take-home message is protect yourself. My vascular surgery colleagues performing endovascular aneurysm repair seem to have no concerns about x-rays, but this is a main issue. Protect yourself. You don't see them, you don't feel them, but they can harm you. Thank you very much for your attention.
Ok, muchas gracias, doctor, por su participación. Vamos a dar un par de minutos para que por favor puedan agregar sus preguntas y en breve el doctor nos estará dando respuesta a cada una de ellas. Tenemos ya algunas preguntas, vamos a empezar a mostrarlas, doctor. The first question is, By Juan Chavez. There should be a periodic review after the stent placement.
Yes, we control the patients with duplex ultrasound the day after procedure and 1 month, 6 months after the procedure, and then every year. It's very important to monitor your stents, because the risk of a restenosis is effective, though since we've started using double mesh stents, these are very, very, very rare. I can see a question from Hilario Polananis Resendis, is that right?
Yes, the question from Lario is... This is the question. Doctor,
Okay.
felicidades y gracias. A grandes rasgos, ¿cómo calcula el diámetro del balón?
El diámetro del balón es calculado con el diámetro del vaso distal, nunca con el tamaño del bulbo. ¿Ok? Lo que interesa es de obtener un diámetro de 4 milímetros, es bastante. Por el CIGARD es importante, he olvidado de decir que el diámetro mínimo de la carótida interna es de 5 milímetros. I'll go on in English, or Spanglish is better. So 5 millimeters is the minimum diameter of the internal carotid artery, because the PET mesh outside has a nominal diameter of 5 millimeters, and it will go perfectly onto the vessel walls only if it's 5 millimeters. If it's smaller, it will leave creases that could favor thrombosis of the vessel, of the stent.
Okay, perfect, doctor. The next question is by José Luis Gómez. ¿Alguna alternativa a Flowgate si no está disponible?
Not that I know. Not that I know. This is a guide catheter by Stryker Medical. It was designed for cerebral procedures. It's at the moment it's still an off-label technique, though the material is tested on the carotid district. I don't know of other single balloon catheters. Probably Vivian Barbieri can answer this question better than I can.
Thank you, doctor. The next question by José Luis. Any tolerance tests before the procedure?
No, we don't perform tolerance tests before the procedure. I'm a vascular surgeon. I was born with arthrectomy, and I remember investigating patients with transcranial Doppler and stress tests, but they were never predictive of what would actually happen during operation. On the other side, clamping time is so low that even if you have a clamping ischemia, it will last not more than 2 minutes, and we feel quite safe performing this without tests before. Anyway, if you should inflate the tip balloon and have a clamping ischemia immediately, you should shift to distal protection. That would be safer in this case.
Thank you, doctor. We have another question by Daniel Murga. ¿Cuál es su conducta a seguir sin el seguimiento y restenosis del stent?
So it only happened twice in my experience of more than 350 procedures, stenting procedures, and we dealt with it with a second positioning of stent in the first case, and in the second case we only redilated the lesion with a paclitaxel coated balloon. But I wouldn't do that anymore because of the concerns of the increase of mortality with these drug-eluting balloons. So imagining a direct flow of toxic material to the brain wouldn't be so, I wouldn't feel comfortable with it. So I'd probably position a new stent inside in the rare evenience, and then there's the best, you can modify your postoperative antiplatelet therapy using silostazole that inhibits in a good manner inhibits stenosis after the stent placement.
Okay, that's all the questions, doctor.
Okay, thank you very, very much for your attention, and a big saludos a todos y gracias por su atención.
Perfecto. Muchas gracias, doctor. Agradecemos a todos su asistencia y damos nuestro reconocimiento y agradecimiento al doctor Tommaso Castrucci por su excelente participación. Por último, invitamos a nuestros asistentes médicos a contestar una breve encuesta que les aparecerá al finalizar la sesión y a que estén atentos de los próximos webinars. Gracias. Now, we appreciate your assistance in this webinar. We're very grateful with the Dr. Castrucci for the excellent participation. Finally, we invite our doctors to answer what we will appear when you close this page. We invite you for the next webinars. See you. Gracias, doctor. Hasta luego.